All month here on the thread, we've been looking into the doctor shortage in Ontario, where 15% of Ontarians don't have a doctor and are on years long waiting lists. This means they usually have to seek care from either a walk in clinic that has no medical history on record or go to a hospital emergency department. So today we want to talk about that. And we have Carly Weeks, a health reporter at the Global Mail, to help us understand what's going on. And we also want to hear from you. So send us a question on Instagram or YouTube. Let's say hi to Carly. Hi, Carly.
Hi, so nice to be here.
Thank you so much for being here. We had a little bit of some tech problems, but it's all good. It seems like if you have a primary care or a physician or family doctor in this province, it's as if you've hit the jackpot. How did we get to where we are here in this province?
Well, it didn't happen overnight. We like to sort of blame the pandemic for everything. And yes, it's caused a lot of problems and really exposed a lot of issues. But this goes back decades. And, I've been covering health for about 15 years, and we've been talking about, issues around doctor shortages for, way longer than I've been doing this job. So, it's a complex problem, but I think it does really boil down to the fact that, for a lot of people, family physicians are, the front door to the healthcare system. So if you have a family doctor, you have someone who can help meet your needs over a long-term basis, can help you avoid going to the emergency room. Family medicine has become a really difficult job. The lowest number of residents are choosing family medicine, and with good reason. There's lack of work-life balance. It's become really difficult. Family doctors are essentially small business owners. It's a difficult job. They don't get paid very much, and they're being asked to do more and more. So I think, that's not the only crisis facing our healthcare system, but it does start to explain a lot. So when you have a lot of people who are moving away from family medicine, it creates just so much other pressures within the system. And that's why, you do see some people going to the emergency room and walking clinics to get any kind of care.
Because they don't have any other options. I remember when my kids were little, because my first child was born in the UK and we moved back and we didn't have a family doctor and we would end up going to the emergency room. But you brought up a lot of points that I want to come back to, including the fact that medical students aren't going into family medicine and the fact that family doctors are, small businesses. I want to come back to that. But you said something that was really interesting and I just want to kind of pull it apart a little bit. How are family doctors or primary care physicians the entry point into the healthcare system?
So really, I mean, if you want to have any kind of medical appointment without having to wait for hours, you're looking for primary care. And I think that in some ways, we don't often think about them as that. We don't think about the fact that primary care physicians and primary care providers, which is sort of a thing we can talk about in a bit, it doesn't have to only be about physicians. I think we almost haven't focused enough on the integral role that they do play. We hear sometimes about, we need more hospital beds, we need more emergency room physicians and cancer doctors. All of those things are very important. And I think sometimes the work of the family doctor, they're kind of like the unsung heroes of the system in that kind of a way. And I think for that reason, sometimes that is reflected. I think a lot of experts and studies back this up in terms of the compensation that they get. They're not considered one of like those sexy specialties, but they do such fundamental work. And so if you're an individual living in a community and, you have, say you're a young adult, you've recently entered the workforce, you're no longer seeing your family doctor back home or, whoever maybe you saw as a child. How do you go about finding one? And if you don't, well, where do you end up? If you sprain an ankle or you need medication, you're heading to the walk-in clinic. You're heading to sort of those stopgap measures, unless you're one of those lucky few who, as you had mentioned, you kind of win the lottery by actually finding yourself a family doctor.
Well, you're going to walk us through how to find a family doctor, but that's in a little bit. I think when we talk about healthcare in this country, it can get a bit confusing because we have the Canada Health Act, and then we have the provinces that are responsible for the healthcare that we get if in this province, Ontario, and then you have your municipal, your public health units. And I think a lot of us became familiar with our local health units because of the pandemic, because they were the ones that were kind of distributing the vaccines, and we looked to them for advice on that. Can you just give us a quick primer on how healthcare is funded in Canada and the different roles each level plays?
Yeah, definitely. So really, we start at the top. The federal government kind of, governs everything, but very little at the same time. So the federal government, writes the checks to provinces and territories. They help fund healthcare across the country. They also do have some say. I mean, they are the creators of the Canada Health Act, which sets out what provinces and territories kind of have to cover when it comes to health. They distribute dollars, and then they also do things like licensing of drugs, making sure that the drugs that we're bringing into Canada are safe, and they're looking at the clinical trials. That's sort of the role of the federal government. There's been more and more controversy in recent years about whether they should be playing a bigger role in terms of the overall delivery of health. That came up recently in the federal, provincial, territorial healthcare discussion. We just had this huge, announcement of billions upon billions of dollars being spent on health in the next 10 years. The federal government kind of said, we want to have a say. We want to make sure that the provinces are spending this money the way they need to, that it's going to things like primary care and mental health and you name it. And so they're trying to attach some strings to it. And some people say they need to be doing more of that. They need to be, putting penalties on provinces that don't live up to their end of the bargain. So that's the federal role. Provinces really are the ones who help decide how the money gets spent. So they're the deliverers of that care. Part of that will be, sending money to municipalities, funding health units. And there's been a lot of changes recently, since COVID, in how that local system does work. And there might be more changes on the way. But essentially, the provinces are kind of the ones who are making the ultimate decisions on, budgets for hospitals, wages for nurses, which has been a huge issue in Ontario. And then we have from there, they're sort of they set legislation for regulatory colleges, which I think we'll talk about in a little bit. But the provinces are kind of they hold a lot of the power over how the way in which healthcare is delivered, and they continue to ask the federal government for more money, saying we're underfunded, we need more of that funding. But they do fund the bulk of it. The feds fund the rest.
And what about municipal public healthcare units?
So essentially, though, they play a really vital role. And so you'll have, municipal health units that typically are funded by, a lot of their funding will come from provinces, but they do, operate as sort of standalone units where they do things like vaccine delivery, prenatal care, postnatal care, breastfeeding, community clinics for a variety of different illnesses. They test water, they test restaurants. They want to make sure that restaurants are safe, that they're they will do inspections and things like that. So they play a really vital role. And some people will be familiar with them because for some people, depending where you live, that might be your entry to the healthcare system. That might be where you're going to get certain prescriptions, or depending again on what services are offered where you live, accessing some of the public health resources there. That's become a stopgap measure as well, and a really useful one, especially in certain areas where there are a lot of underserved, marginalized individuals.
I think the fact that we live in the GTHA, we don't realize that in some communities there you don't have access to hospitals. You might not have access to a walk-in clinic, and it can become very difficult to try to navigate the healthcare system. And for anyone who's watching, if you do have a question for Carly Weeks, please send it to us. And Carly, we have a question coming up, but I wanted to just have a follow-up to what you were just saying about the federal government and the provinces and territories recently met because they were asking for more money from the feds. This past summer, we heard about ERs closing for a period of time, people having to drive hours just to get help across the country. The federal government has stepped in and they've invested $73.97 billion, which sounds like it's such a huge amount of number, but that's over 10 years. And that's, of course, across the country. How much does this money really help?
It does help in a big way, because we do know that, per capita, compared to other similar countries, we have a very low number of hospital beds. So, we know that we need more money. We know that, nurses are not getting paid what they're worth right now, PSWs. So there's an argument for more money, but that's not going to get us where we need to be. So, because the argument goes, if you're simply spending more money on a system that is not working, and you're expecting things to change, they're not going to. And so I think that.
But Carly, let me just push back really quickly. I don't want to interrupt you, but that this is what the premiers are saying. They're saying that the reason why they need more money to make the system work.
Mm-hmm. And they're always going to be saying that. They'll always ask for more money, I think, no matter what they get from the government. And that's what they do. They go and they ask for more money, but at the same time, they also are responsible for making sure that the system is operating in a way that is actually efficiently using that money. So I think a good example is when we talk about family medicine. And I've had many conversations with family physicians, family health experts who say that the way we're currently doing the system, and there's been more and more attention paid to this. So I guess this is the way I would push back on that narrative, is that this is what I'm hearing from family doctors. If you're just simply going to, put some more money aside, create more residency spots, you're going to make it, you're going to create space for more family physicians. Well, that's not necessarily going to work, because historically low numbers of people are choosing that as a specialty because of the way it's structured, because of the way their workday is basically going to be for the next 3-4 decades. And, a lot of them are avoiding going in, knowing that they're going to never be able to leave. They're never going to be able to find someone to take over for their patients. It's become a bit of a very difficult, thankless job in some ways. And so I think, that's when people are talking about more money is not going to solve the problem. That's kind of what they mean. We need bigger policy changes that are going to make sure that the money we are getting, an increased amount of money, is going to, go toward ways that are going to make our system work better. Keep people out of the hospital. Have, community teams of health providers, nurses, social workers, dietitians available in every community where people live, so that they're not having to go to the emergency room in a crisis and then get admitted, and then they never are able to leave, and then they become an alternate level of care patient, or ALC. And that is the cycle that a lot of patients go through right now. Can't get the care, end up in the hospital, then you're called a burden on the system. And now the government just passed legislation that they can sort of ship you to a nursing home that's not in your community, instead of addressing the root problem.
You mentioned an acronym there, ALC.
Yes, yeah.
What's
So
that?
alternate level of care. And essentially, I'm sort of smiling, but there's just been so much controversy in this area. I mean, these are really sick individuals who have been called a lot of derogatory names, like bed blockers. That they're the ones, they're clogging up the system, and we're really talking about people, lots of frail elderly people and others with chronic complex healthcare needs, who essentially don't need to be in a hospital, but they can't go home. Their needs are complex enough that they need some kind of assistance somewhere, but there might not be a bed for them in a long-term care facility, or a long-term care facility may not take them because their needs are so complex. So they get stuck in the system, and we've kind of have started to blame them more and more for, well, that's the reason why we don't have hospital beds, because all of those people are clogging up the hospitals, when in fact it's actually, we could be doing a lot more to prevent those hospitalizations in the first place. And again, it goes back to the way our system is structured. So much is kind of left to emergency room physicians and nurses to pick up the pieces of where our system is just not, working.
I think we've all been there, where we've been sick and you just so vulnerable. And I'm thinking of these individuals kind of being blamed for being sick, and kind of what you just said, so-called clogging the system. We do have a comment for you. We're going to bring it up. Okay, my eyes are so bad. I'm going to try to read this. It says the entire system needs overhaul, support, funding, and privatizing isn't going to help an already suffering public system by removing funds from public health to fund private health. Apologies, everybody. I'm sure you saw my pores up close. My eyes are really bad. But Carly, what do you think? What do you make of that comment?
I think that is true. I mean, privatization in a big way is not sort of the answer here. I think that a lot of people sort of think, if we can just use our credit card, get to the front of the line, give people an option to pay, it's going to get rid of the backlog. It'll create another option for people. And I think it's an overly simplistic view of how we get out of the current mess that we're in. That being said, I think that when we talk about privatization, we're not necessarily all talking about the same thing. And I think a lot of Canadians sort of feel like privatization means you're going to have a hospital where you have to pay for everything. And really, we already have, 30% of our care delivered in Canada is already private. Family doctors are basically, private companies. You have sort of standalone clinics that are doing all kinds of diagnostic tests. So we have a lot of privatization in our system already. I think, again, there are some people who are just adamantly opposed to any more involvement from the private sector. I think that those people who are kind of in the middle of the road say that, we cannot even talk about building a secondary private system given the mess that our current public system is in right now. And we need to think bigger about how we address some of the current problems we have. And I think that one of the other arguments is that we just keep talking about the fact we have problems, and we're not hearing from our elected officials or other leaders about the big solutions that they have, like the real bold changes that are needed. Medicare in the 1960s, that was a huge deal, very hard fought to get that into place. We're talking about that, almost that kind of a level of generational change that's needed. And I just don't see that conversation happening anywhere.
We've got some solutions because in this show we try to offer solutions because, as you know, the world has a lot of problems indeed. I will mention that while we were traveling this month to look at the shortage of family doctors, primary care physicians in this province, I spoke to a couple of people who didn't have access to anything and were on a wait list trying to find a doctor for 2, 3, 4, 5 years. And they said that if they had a private option, that they would actually take it.
You can really see why that would be so tempting to a lot of people. There's so much frustration with the system right now that I think a lot of people are throwing up their hands saying, well, this isn't working. We need an option because I cannot wait any longer. And the fact that we've sort of driven people to that point, I mean, people are really suffering and struggling and cannot get the care that they need. Physicians are upset at this. Nurses are upset. People are burning out. They're leaving the profession. This isn't working for anybody. But I think that the idea that, if we're just going to, create some clinic or hospital where you can go and pay, and that's going to sort of solve the woes. I mean, it might solve the woes of a handful of people right now. But then what happens when, a lot of nurses and doctors are siphoned away from the existing hospital to work over here? And so someone is not being served when our system is not functioning in a way that is maximizing everyone who is licensed to work here, working to the top of their ability, making sure that people are on top of their health, helping people maintain their health and remain at home. I mean, these sound like pipe dreams, but other countries are embarking on these kinds of plans who are keeping people well in place longer. And I think that's really where so much more of our focus needs to be. Again, it's not an overnight solution, but things that we need to start thinking more seriously about.
I want to ask you what jurisdictions are doing well. I'll come back to that question in a second, but we do have a question from someone who's watching our conversation. Veronica says, is there a difference between the GTHA and other areas in the province? What are the wait times for someone outside big centers? I have friends in Toronto that have been waiting for a family doctor for 2 years now.
Mm-hmm. There are obviously big regional differences. And I think that, when you're in a large city, you often have a lot of things at your fingertips. You have bigger hospitals, you have the advantages in that way. But yes, at the same time, there's obviously struggles in big cities and small ones. I would say that, as is the case across Canada, those living in more rural and more remote areas are facing longer waits. There are simply just fewer providers there, fewer walk-in clinics, fewer hospitals, fewer other options. Places like Northern Ontario, where to access certain kinds of medical care, you're actually having to leave the city. And we talk, healthcare by postal code. I mean, that's where you can really start to see how where you live starts to impact your quality of life. When, if you don't have access to a car or you don't have money for a hotel room, and yes, there's subsidies available, but it's very difficult. So I would say, but that is a truism across Canada. People who are outside of big cities often fare much worse, and it's not great in big cities either.
You're from Sault Ste. Marie, right?
That's right. Yes.
How frustrating is it up there?
It's really frustrating. It's palpable. My dad's family physician recently retired, leaving a lot of patients without a care provider. That's an area of the province where the life expectancy is several years shorter than it is in Southern Ontario. You can point to a lot of different social determinants of health for that reason. Lack of access to a whole variety of things that help people in other more have parts of the province prosper and do better. When it comes to simply just primary care and things like that, there's such a shortage in my hometown right now, something that we're hoping to maybe even write about, but just people who are pregnant having to really scramble to find care. There's no one to help monitor pregnancies. Record wait times in emergency or in the hospitals for emergency waits. And again, anytime you need to see a certain kind of specialist, you're hitting the road, and it's going to be 3 to 5 to 8 hours before you see someone. So frustrations across the board there.
We did get a comment on our Instagram page from Karen Osler, who said, in Northern Ontario, we have access to even less services. I've been on a wait list for over a year to see a neurologist and psychiatrist. They're telling me it's going to be another 6 to 12 months. Also just had to drive 8 hours to Ottawa to get my toddler tested for a penicillin allergy, as this service is not available in my town. Beyond frustrating. And that was a comment that was on our Instagram page. One of the things that we've been talking about the problem, and we're going to talk about solutions in just a second. But something that was told to me by some of the people we spoke a lot in the past few weeks was that for a lot of people, especially young men or men, accessing care, if it's so difficult, if you're trying to find a doctor, or if you're trying to seek help and you can't find it, that sometimes what ends up happening is that you only get help, or you only look for help when actually the problem is much, much worse. How important is it for us to keep that in mind?
I think that's huge. And I think that speaks to the point of, how, just how poorly functioning our system is right now, I guess, is one way of encapsulating that. But, I think just to that point, I mean, there are so many different people who are struggling and, who are kind of being disadvantaged by the system, the way it's set up right now. And, your comment about young men, actually, like, it just got me thinking again about, Northern Ontario and Ontario across the board. And another thing that we're still continuing to see is, the opioid overdose epidemic is continuing to be such a huge problem. And a lot of young men, they tend to be the ones who die most often as a result of overdoses. So, and I those are sort of, you could argue they're tangentially related, but I think they're inextricably linked, because when someone is completely detached from the healthcare system and they have no one to turn to, and say they do fall into a pattern where, maybe it started out as a prescription for a walking clinic or just something that they got from someone at work, not having a care provider or any access to any kind of, person as part of a family health team that can help you navigate through what could become a crisis. I mean, that's a contributor here as well. And people medicating themselves, who work in some of the trades, like, that's become a huge issue, and it's not getting any better with the lack of access.
We have a comment here, which leads to my next question. This is from Ivan. Ivan writes, my doctor says that the problem is largely caused by the federal government not funding sufficient places in medical schools. Would that be a provincial jurisdiction? Because last year, the Ontario government announced that it would add 450 new seats in Ontario medical schools. Can you help us understand that a little bit better? And would that be enough to make a difference in what
Mhm.
we're seeing with a doctor shortage?
Yeah, I mean, I think that is a real important point to make. We know that we don't have enough residency spots right now, and there is, I think, a role for the federal government to be playing in terms of making more space available for in terms of funding. There's always more funding that's needed. The provinces are going to be the ones who are deciding, kind of how that all shakes out on the ground, and in terms of spaces and things like that. But just coming back to that point about family physicians, I think it was something like the last time that it was looked at, only about 30% of residents were choosing family medicine, which is just the lowest level on record. Um,
Why?
it's frankly a bit of an awful job to take on. You don't earn very much money. You work around the clock. You're taking care of so many different people, and the way that family doctors are funded in most of the province, it almost ends up just, you're having to work without compensation. You're doing paperwork all the time, and it's not worth it. So without getting into the weeds too much, a lot of family physicians work on a fee for service basis. So basically, you see a patient, you perform a procedure, you do something, you get paid. And so that can incentivize just sort of seeing a ton of different people, volumes of patients coming in. But a lot of family physicians do want to take the time. They're not just going to sort of like whip people through the system, so they end up having to work really late to fill out paperwork. To They're not getting compensated for the care that they're providing to patients, and that's not fair. And they're working so hard, and on top of that, they're running the office, so they're having to pay their staff, they're having to keep the lights on, buy medical supplies, you name it. It's a really it can be an awful job. And you have so many people in the community who are desperately seeking your services. Um, and then you have this pressure that I've heard a lot of doctors describe as well, that some people don't even want to get into it because you just know that you're going to leave hundreds of people hanging if you ever decide to relocate, if you can't deal with the pressure of the job. The preferred option that a lot of health leaders are talking about is a sort of a capitation system where you're basically in charge of a roster of patients, and you're going to get paid fairly. You're going to see, X number of people, and you're going to get paid for that regardless of whether you spend 2 hours with one patient and 15 minutes with another patient. You're giving your time based on the care that the patient needs, and you're going to be compensated fairly. But for a number of reasons, that's really not the model that has prevailed in Ontario today. And so for most people, they end up stuck in that model of, trying to find a family physician who's overworked, who doesn't want to be there, when really we could be using, family physicians in such more efficient ways, working in teams with other care providers too.
One of the family doctors that we spoke to said that a quarter of their time is spent on paperwork.
I don't doubt it. It's, and I think that we often think about doctors and you look at, well, that family doctor earns, 300 a year. What are they complaining about?
Mhm.
It is a really, really difficult job, and they're having to see so many patients, and again, paying for their staff and their offices out of their salaries. So they don't get paid very much, and they're working very hard. And it's time that we really start to address the root issues here.
I didn't realize that if a family doctor operates or gets their license accreditation in Ontario, that if they were to move to, say, I don't know, BC, that it would be very much different and they would have to get more accreditation. Federal Conservative leader Pierre Poulin has called for a national standard system so doctors and nurses can work in any province or territory. How does that alleviate the doctor shortage?
So, I mean, there's been more and more talk about this need to basically fast track people. You want to work here and you have the skill. Let's figure out a way to make this happen. And, overnight it's not going to solve the problem, but I think for those people who are out there waiting, it will make a difference in those communities where those people are setting up shop. I mean, are they family doctors? Are they going to have to work in this thankless environment? They might not stay very long. So again, that's that long-term idea of we can create the space, but if it's an awful work environment, they're not necessarily going to stay. And that's what we keep seeing happen in Ontario. So there's a lot of merit to the idea of streamlining this process, but again, thinking long term of how do we make family doctors want to stay family doctors, and how do we make that a really lucrative, interesting, exciting place where you want to come to work every day. That's where a lot of the discussion needs to go. And I think it is, I think, refreshing to see our federal leaders talk more and more about solutions for health. I think that, the solution that Pierre Poilievre was talking about is probably a bit overly simplistic, kind of saying you're going to fill out one standardized test and everyone's going to be licensed right away. I mean, I think he knows it's overly simplistic, but it sounds really good. And it does speak to this larger point of we do need to streamline things. And, people from the Canadian Medical Association to, everywhere, they've been calling for that same thing. I guess the point is that, once we do, and hopefully that those changes happen, we can make it easier for people to relocate so that you can change provinces, you can locum, so you can temporarily work in a different province in an area of need. We desperately do need that to help alleviate some of the bigger problems that we have. It's not going to solve everything, and we do need to think bigger about how we're sort of forcing, family physicians and others to work in this, crumbling system.
During the height of the pandemic, we heard stories from foreign trained doctors who were essentially begging to be allowed to help people and to do what they studied for. And we heard from different, I think, from Ford and different leaders across the country saying this was something that was in the works. We have a question from Veronica, and Veronica wants to know, why don't we license the international doctors we have in the country? Why is it so difficult for them to enter their profession in Canada?
Mhm. I think the short answer to that is that, I don't know. I think that that's one of those low hanging fruit areas where we can really start to target that and say, this might not be the solution to all of our problems. But if you have people that are here wanting to work, and we can likely, test them to make sure they have the same standards of, that Canadian doctors and nurses work by, or we can somehow help them get their standards up to where they need to be. Why aren't we doing more of that? And I think that part of the explanation comes down to, a bit of complacency, us kind of ignoring some of the, systemic major healthcare problems that have been going on. I think that for too long we swept a lot of these things under the rug, and we sort of were like, well, that's a crisis for another day. Because, people have been like healthcare leaders have been trying to call attention to this, what they've been calling a crisis for many years, and it just has not resonated. And now, of course, everyone is talking about it because no one can get in to see a specialist. They're waiting years to see one. They're, having to wait, months longer than necessary for surgeries. So I think that that's an area where we could see some movement. Hopefully we will. But it's not, at the same time, it can be complex as well, because you want to make sure that there's, the same standards that are being applied. I think it was Nova Scotia that is saying they're going to start recognizing credentials of American physicians, basically saying, the two countries are so close to each other that we know that the skills and standards match each other. So, there are some innovative solutions at work, but yeah, we need more of them.
It's interesting you mentioned Nova Scotia, because we spoke to a foreign trained doctor. She studied in Jamaica, and she's been trying to find work as a primary care physician in this province and hasn't been able to. We traveled to a town by the name of Marmara, and they've been looking for two physicians for a couple of years now, and they're incentivizing. They have a bonus that they're offering, free accommodation, but yet they haven't found those doctors. I asked her, I said, would you, if you had the opportunity, practice in a town like Marmara? And she said, without missing a beat, that yes, I would.
Wow. And see, that's where, the solution is kind of looking at you right in the face. And I think that, Pierre Poilievre has the idea that he's floating. Again, it's overly simplistic, but that's why I think it has captivated a lot of people, because it's like, well, yeah, we should have been doing that a long time ago. It does take some work. It's not the easiest thing to do, but of course, there has to be ways to streamline this process. We are talking about it more and more now, but still, this is, a long time coming.
Well, you mentioned that other places are doing it well. What jurisdictions are doing this well?
Doing it well in terms of,
As far as innovating what's happening with the shortage of family doctors.
right. So, I think one area I would highlight is actually in Ontario. And I think throughout Canada, there's so many different bright spots. And I just want to say that our health professionals are heroes. They're phenomenal. They're working in the confines of a system that is so difficult, and they move mountains, every day for their patients and do whatever they can. But the reason why I bring up Ontario is that I think we kind of have the solution we need right here at home, and that's family health teams. And if you know what they are and how they work, you probably are in agreement. And I
What are
sort of,
they?
well, basically, it's exactly the way it sounds. So you're basically a patient of a team of care providers. Um, I have firsthand experience. I actually was a patient, and still am, of a different family health team, and I quickly realized, probably after having kids, just how valuable a resource it is to
Mm.
essentially, as a patient, you have a roster of healthcare providers at your fingertips. So if your child, as mine was many times, coming down with some really weird rash, or something,
There's always a rash.
there's always a rash and something really scary going on. I would literally call up the office and they would say, come in right away. There was no waiting for appointments. There's, someone who's going to be there to see. It might not be a family physician, it might be a nurse. And it didn't matter, as long as there's someone there who's going to be able to look at your child and give you medicine or tell you what's going on. And so there's among the professionals that work in these kind of family health teams, physicians, nurses, nurse practitioners, who have a lot of prescribing powers. There's social workers, dietitians, physiotherapists, occupational. It depends on where you live and who's working in them. But these are really amazing teams that are able to provide complex care to people over the course of their lives. And the people that are patients of them, I think the evidence shows how valuable they really are. The province stopped funding them. They basically capped the number of family health teams in the province, and because they said, and I think that there's maybe been some validity to this argument, that they are spending a lot of money without any kind of accountability measures in place. So I think that's an important point. We want to make sure that you're actually getting value for that money, and doctors are accountable, et cetera, et cetera. But that has really become a bit of like that holy grail of this is what we need to do, because not everyone is going to be able to see a family physician. We're not going to be able to produce that many in the next couple of years that we need to meet those. And that's why I was saying earlier, making sure health professionals are all working to the top of their scope of practice. I mean, why like clear away some of the hierarchy and the territorialism that can sometimes come in health professions, and have everyone working together to the top of their ability to keep patients well, to give them what they need, and keep them out of the emergency rooms and hospitals.
I could talk to you for another hour, but we only have a few questions left. If anyone has a question, please put it in the chat and we'll come to it. So I'm pretty sure there's, I don't know, for me, I begged my friend, one of my friends, I'm like, please, can you talk to your family doctor to take my family on, because I went on the website, I did all the things, and I couldn't find a family doctor. And thankfully, my friend is very persuasive, and I was able to get a family doctor. But not everybody is that lucky. So, for anyone listening and who's trying to find a doctor, what are the steps?
Yeah, it's not easy. And I recently moved, and so I went through the process of having to find a new family doctor not that long ago. And so I can attest firsthand to the fact that it is a real jungle out there.
Mm.
So essentially, your first line often becomes, looking at the Ontario website. You Google, like, find a doctor in Ontario, and there is a website that's dedicated, that's run by the government, that will kind of tell you doctors that are accepting patients in your area. There's also a service called Healthcare Connect, where if you sign up and you give all of your excuse me, don't need to see a doctor just yet, but you basically give all of your healthcare information. You have to attest that you're going to give up any existing relationship with a care provider that you have, and they will find someone for you, or so they say. I know from people that have tried this service that the results are mixed at best. You might end up getting paired with a provider that doesn't, really meet your needs. It might take a really long time. So I think that for a lot of people, what they end up doing is they simply are calling around constantly, trying to find anyone within their community that's taking new patients. Where I live, just outside of Toronto, there's a lot of, doctors that are working in sort of a clinic, like a walk-in clinic, who started to take on more and more patients from the community. But a lot of people will, in essence, just start using those walk-in clinics as their primary care, because there's no other option. We ended up lucking into getting in part of a family health team again. So I feel very privileged, and I'll connect that point in a second. But I basically called around to enough places and explained that my daughter needed to have her 18-month needles. And so someone, like a very kind receptionist, took pity on me and said, okay, fine, here's the doctor in our office that actually is taking new patients. But it's almost like, you need to be like told about the secret speakeasy, and here's the code word, and then you can get in. And I said the word privileged with, on purpose, because it's people like me who end up filling up the rosters of family health teams. People who are living in higher income areas, who have more education, who tend to have better health outcomes. And it's the people who are marginalized, who are often living in lower income areas, who are often racialized, who have poorer health outcomes overall, who are not able to access these services because they're working. They don't have time to spend hours on the phone or looking at their options on the internet. And, sometimes there's even been, discussions around whether or not family health teams are taking on patients like that when they do get approached. So that's a whole other topic of the inequity of who is getting that access to the system right now. And it's oftentimes the most vulnerable people who are struggling the most and will continue to suffer the most.
I'm glad you brought up the equity lens, because in that town that we were in, that town was mostly seniors who were going to, like, the repercussions for their health. Like, you have to drive a couple of hours outside of your community to access care. You talk about mobility, about having access to figure out what's to navigate the online system, and again, keeping on the thread of representation and equity. Sunny Ray 784 left this comment on our Instagram page. They wrote, I joined Taibu, which is in Toronto, Community Health Center, Scarborough. It did take a while, but I was adamant on finding a Black family doctor. Again, how important is it for us to kind of talk about that when we are talking about it feels as if you do get a family doctor, any family doctor will do, but how important is it for us to talk about how important it is to find a doctor that meets your needs?
It's hugely important, and we don't talk about that enough. So I really thank that person for that comment. For people who are like, you want to be represented by your healthcare provider, we're talking, very personal, intimate details. You want to make sure that you have a comfortable relationship with that family provider. For some people, that might be someone who can speak their language, someone who understands their culture and background. One of the key problems that we've had is that we collect very little data in Canada on our healthcare workforce. Period. We can't really say with any certainty what the diversity of the workforce is, who is working where. I mean, that's a huge gap in our system. That's one of the reasons why we literally can't say with any certainty how big is our nursing shortage and how many nurses do we really need to properly make sure our system is up and running. So part of this new federal, provincial, territorial funding agreement, the federal government is trying to, we'll see how it goes, attach some strings saying that provinces and territories need to get better data collection methods on what does the healthcare workforce look like. And so a lot of groups are really pushing to have some of those really rich demographic details captured so that we can start to get a sense of just how far behind we are in terms of having a workforce that actually is representative of the communities that they're serving. And that's something, we're probably decades too late in coming to the discussion on, but that's certainly something that is now on the agenda at least. But yeah, I think to your point, we're at a place where, any family doctor will do. And, that's probably, it's not good enough.
And I guess just to follow up on that, how does the system leave out certain demographics?
I think in huge numbers of ways. I mean, I think there's a lot of inherent biases in the system. So, people who are, feeling like they're marginalized and not comfortable going into a hospital or healthcare setting, groups that have traditionally, there's a lot of mistrust. A lot of experiments were done on Black communities involving vaccines that sowed a lot of bad faith and mistrust of the medical profession. This is going back decades, but that stuff sticks. These are things that we haven't properly really, I think, addressed. I mean, we've had some of those discussions during COVID, but so sort of some of those things that that's right, like that word inherent, where people who want to access the system not feeling as though there is a place for them, maybe being judged or discriminated against, and then saying, well, this is not a place where I can go and seek care. There's people who are experiencing homelessness who can't make their medical appointments for a variety of reasons, like not having a cell phone, and the people who work at the hospital or the doctor's office are refusing to rebook them or see them because of the way they look and dress and act. The same goes with people for people with mental illness. And so oftentimes the people who are included and do best in the system are people that can navigate it and advocate for themselves. And those are the people that will likely have better outcomes. And that's not it's simply not a fair way of doing things, and it's not equitable, and it's certainly not universal. And it shouldn't be that way. It shouldn't be that your ability to sort of navigate for yourself and where you live and how many resources are at your disposal should not dictate how healthy you get to be.
I want to wrap up with this thought. A few of the healthcare providers we spoke to spoke about moral injury. And it's this injury because if you're in that profession, if you went into public healthcare, you want to help, or even the doctors, the nurse practitioners, the people working behind the scenes, social workers who are trying to help people, but there's not enough bodies, and there's a lot of people who want those services. And they said to me that they feel as if they're letting people down. It's affecting their mental health because they're not able to fulfill their jobs in the way that they want to. And, you've been covering the pandemic, and I have to say thank you so much for the incredible work that you've done. I've been reading you throughout the pandemic. I've learned a lot. And I can't imagine what that does to, you've seen the system, you've seen it progress to the point where I don't think any of us were expecting the pandemic to impact our lives the way that it did. And so I'm just kind of curious, are there any reasons Ontarians should be optimistic? And I guess what makes you hopeful in the work that you do, that this is something that we can change, this is something that we can make better for the people in this province?
Mhm. I mean, it is difficult at times to be optimistic, and certainly when you hear our leaders talking about solutions that are clearly not what the experts are asking for, it can be a little bit tricky to sort of see the light at the end of the tunnel. But I really think that our system, we're talking about health in a more meaningful ways than we probably ever have, and issues of equity and the social determinants of health are kind of making their way to the top of the agenda. So I have hope because I look at some of the people who are working within the system to change it, and the programs that they're developing, and kind of the MacGyvering of the system. They're going to do what they can with what they have, and they're going to make it work. And they're going to be the disruptors. They're going to be the ones who are, changing things from the inside out. And, one small anecdote, I had the recent fortune of interviewing new chief nursing officer of Canada. And she described seeing a lot of nurses with moral injury and how difficult that is. But, she is someone who, a couple of years ago in 2015, she suffered the loss of her brother to an overdose in Toronto. And her brother had been experiencing homelessness for a long time. So what they decided to do, she and some colleagues, is they basically set up an unsanctioned, supervised consumption site in Moss Park, a very underserved low-income part of Toronto. And without anyone's permission and very much against the law, they started to provide clean needles, provide a safe place for people to use drugs. They reversed overdoses. And now this person, in that site ended up getting funding. They saved a lot of lives. And now this person is within government, working to change the system for the better. Those are the examples of the kinds of people that are going to drive the change we need, and who give me hope for the future. And I think we should all feel hopeful. It might not get better overnight, but it will get better.
Carly, thank you so much. We really appreciate your time. And you can follow Carly's work with a Global Mail. And you mentioned MacGyvering for all the non-Gen Xers and older. MacGyver was, a guy on TV who basically every week he could, I guess, solve a problem using what, like tape and spit.
Basically, yeah.
Basically, look it up on YouTube. But thanks everybody for tuning in, and for everybody working behind the scenes, and for all the questions. Really appreciate your time, Carly. Thank you so much. Really appreciate the work you're doing.
Thanks for having me.
All right, bye everybody.